And our next speaker is Matt Hsin from Taiwan. He will be talking about bleeding during bariatric surgery.
Now, in the next two topics, I will talking about the breathing and the leak issue about the bariatric surgery. I think just as Dr. Atif said, however, experience how good you are definitely encounter this kind of complications. It's a part of our life. But I think the difference is, could you able to safely bring your patient back to their home? I think it's something we could understand. Okay, I think here I will share some procedure we do and the sleep bypass and sleep plus what we encountered in our past. The first thing is why it matters, because breathing is always the most common trigger for early intervention when you bring a patient back to your OR. So although it's some classification acute, early, late, chronic, but usually 99% we encounter always acute breathing just immediately after operation. So, but something we have to carefully thinking about. Breathing is not a sequence. It is a sentinel. It is a hint, a sign to you there should be something wrong during your operation. To make the patient breathing and bring them back to OR. So the study intended. Actually, the breathing have a subsequent leak after the postoperative breathing is rated higher than normal one. So with and without breathing actually result different. But as the tip said, mostly when we do the sleep, the best operation, the most things we encounter always the vasal region or the abnormal region. So like sleep, the most common always stable line, the great omentum, the short gastric region. But for anastomotic region is also a potential risk. So like a RUIGB and some MGB margin or the connection pipe, always a high risk region for the breathing. But whatever was thing, when we encounter this kind of this kind of thing, I think that something we have to remember is always keep your patient stable, do a resuscitation, early intervention. So the first one, sleep. The breathing of the incident of sleep is being documented around 1 to 6%. So that's the first case we encounter in our hands. That's a picture of the OP record. So for that kind of thing, you can see there's something wrong because it's not a very quick onset one. So we got time to check some data. So you can see the hemo concentration in the first day after operation. So let's see the video. This is a typical picture. You see the burning of blood coming from the muscle of your sleep. So I think when you get in to see this kind of things, always try to explore the lesion site. As you do, usually we will use a cautery to stop the breathing. It's safe for us, but I think the point is after you do the hemostasis, you have to pay some time clean the field and then make sure the stable line is intact. You know, after the breathing, there's maybe something wrong in the whole section of the stable, not only a single point. So it's better to look and check, make sure the whole stable line is good, better. So in this patient, the patient have the blood loss in the OR is more than 2 liters. It's crazy, but it happens. So when you review the data, so when you go to reduce benchmark, actually the posterior breathing rate is not so common, it's only less than 1%. Not very common, you need to bring it back. But my deeply suggestion is that don't wait. When you feel something wrong, bring patient back. Sometimes this kind of considered treatment, if you do not improve, go back as soon as possible. Don't take the risk. But when you get in, when you check the stable line, we feel there's something wrong, like the patient, if you do some calculations, still not works, I think the stable line reinforcement, reinsuture, reinsuture will help this kind of things a lot. So if you got the absorptive VLOC, sometimes it helps make your suture easier and quick. So for this first case, what we do the laparoscopic evacuation, hematoma, identify breathing point to hemostasis and put gen, so the patient could easily and safe to leave or go back home. But when the conservation range is appropriate, sometimes the patient, patient complain about fluid, about pain, some sweating, but relative hemodynamic stable. Actually, you get some time, some chance to do some exam for your patient. So if you do the fluid, you do the blood transfusion, patient becomes stable, you have chance to do a concept treatment. Because bringing the patient back to OR is a very high pressure to doctor and to family. But these two cases is not suitable. So let's another case is a massive bleeding one. In the basement, the background of this patient, actually he is end stage renal disease in hemodialysis patient. You know the something wrong. So it's the vital sign. So just immediately after the operation, in the same day, you see the dropping of BP very quick. So there's a picture. So when you get in, you see the bleeding from the edge of the omentum. So that is something I want to suggest. Don't trust your energy device too much. So you know when you feel this patient is a trouble patient, not stable, when you're doing a dissection, try to do a calculation twice. Don't to trust it. Sometimes it's really dangerous. And also because in our habit, during the operation, we are always asking our anesthesiologist control BP around 100 or 110. But when patient go back, BP may elevate during the pain, something go to 130, 150. So there's still some chance of risk have bleeding. So the monitor in the ward after operation first is quite important. So I think that something for the bleeding issue is the bleeding is a sign of a leak. So be careful. When you get in, check the bleeding. Don't go away immediately. Make sure whole stable line is good, solid. And the source very stable line is the most common, but like another case, the greater omentum shortcase region will be also the potential risk of bleeding site. And both these cases will recognize early, so we go intervention early, so you could safely resolve this kind of issue. But for the rural gastric bypass, bleeding is another story. Actually, for 9 years ago, the 90% in our center will be rural gastric bypass. In that year, we have to do 300, 400 cases per year. But nowadays, almost become zero. So I'm sorry I could not provide a lot of video, this kind of video for the rural gastric bypass bleeding. But usually, in the past, when you encounter this kind of bleeding, always come from GJ if immediate after operation. So for acute GJ spiral bleeding, always happen early. And the most we choose the endoscopy treatment first. But in the contrast is when the patient already have another long period, when they go back from the ER, most coming from marginal ulcer hemorrhage. So it's most coming after weeks, months after operation. And most this kind of bleeding could manage it conservatively, but it's always something happen. Smoking, the most common issue we encounter. Although we try to persuade patients do not smoking, but you know sometimes it's quite impossible. But for the rural gastric bypass, acute GJ bleeding, usually we try to use endoscopy first. So you know the majority are coming from there. So, but you have to make sure your GI man understand how to help you. Do the hemostasis, use a clip or do some repair. Usually could control the most major bleeding. But once your GI man said after 1 or 2 times scope still not able to fix it, you have to get in to fix the problem by yourself. And the marginal ulcer is another reason of bleeding. Is mean prevalence in the marginal ulcer every record is around 4.6%, but in Taiwan, in our data, actually is 20%. So that's another reason we quit to perform the rural gastric bypass in our hands. For a long-term, too many complications you need to handle. A lot of risk factors has relationship to the marginal ulcer, smoking, NSAID. And another thing recently being documented is the medication for anxiety for the pressure is SSI medications. And the less more modified like HP infection and the large gastric pouch and some gastric fistula may also cause this kind of bleeding. But during the survey from scope could help you to clarify the reason. So something that maybe I will try to remind is a lot of obese patients got anxiety issues, so they very frequently take this kind of medication. So once you find your patient have this problem, you have to check his medication and then make sure, try to quit this kind of medication temporarily. Try to make it safe in the first. And urgent endoscopy or urgent surgery, I think all depending on the hemodynamic status of your patient. So if it's relatively stable, especially in right gauge bypass case, actually mostly the GMN could help you solve it. But once not, go back to OR as soon as possible. But for the full surgical management, I think I think we got two excellent speakers will tell us how to manage that. But I think the last for the breathing I will say is some medication helps, like currently when we encounter this kind of breathing, we try to use octreotide, the central try to decrease the breathing. Actually, it works. So in the acute management for this kind of active breathing, the tranexamic acid and the central usually the most common medication we will use. It could help a lot. So you could try to give you some more space to do the next step. Okay. So for the right gauge bypass breathing part, I think acute GI breathing is probably you could ask your GMN to have first, not to OR unless the patient is really unstable in hemodynamic status. And but in the long run, marginal ulcer is always making you in big trouble, because in the high peak era, every week we got patient come back from ER for the marginal ulcer breathing issue, and be sure a patient is his medication is safe. So once the patient take SSRI, SNI, you need to make sure this kind of medication is under protection of your PPI medication. So another part is the sleep plus breathing, because I want to share is nowadays the majority of our center we do the sleep with small bowel shortening. So we cut the small bowel and make a small bowel sponge and osmosis. So something wrong will happen during the intraluminal breathing. So this one of the case is after operation, patient got a bowel obstruction. You see that the swelling small bowel. So although we use the central statin try to stop it, but patients still have an obstruction sign. So when you get in, we will see that sometimes this kind of happens is the intraluminal breathing. So you could see that when you open it, there's a breathing from the lumen, from stable line. But interesting, in the long time ago, when we do the right gauge bypass, this situation very rare to see. But once we do this kind of sleep plus operation, because we do anastomosis in the mid portion of the gut, so the thickness of bowel wall is not so thick as the proximal jejunum. So this kind of breathing is more common in our hand to see. But whatever I think in the last is that these three cases all managed safely and leave the hospital safely. But what I think is that when we encounter this kind of situation, make sure your patient is in hemodynamic stable status, and once the things out of control, go back to the OR immediately. Sometimes the 1 hour, 2 hour delay will make the situation totally different. And laparoscopic exploration and source control is the first thing when you get into the OR. Sometimes you could not stop breathing immediately, so where compression is good, it's very important that you have some time to take next action. So don't be panic inside, and make sure all the team, including anesthesiologist, prepare everything well to let you safely help the patient. But the escalated supportive care after operation is quite important. So make sure resolve the problem immediately, control breathing, but you have to consider anything wrong of the operation. Okay? So I think the last slide will be that sleep breathing is a sign of leak. So carefully, when the patient got a leak, make sure stable line is intact, good. But for right gauge bypass, endoscopic, the GMM will help you a lot. So you should be the first line your patient in the hemodynamic stable status. But in the future, you do something, if you like us do the sleep plus surgery like a small bowel bypass, Sometimes this bleeding coming from JJ and stenosis intraluminal, so carefully, the CAT scan will help you do the survey. Okay, that's the first part about the bleeding issue. Okay. Then we go to the hair leak. I think the leak after sleep always a nightmare for bariatric surgeon. So like me, when you're talking about leak, the first, oh shit, always the idea come to your mind. But you know it's a part of your surgery, a part of your life. You will always encounter leak, how good you do the operation. But I think that there's something that there always some timeline tell us acute, early, late, chronic leak, but leak is leak, whatever acute or chronic, all of them are very hard to manage. The first thing we are talking about the sleep leak and bypass leak. For the leak, the most common from the stable line failure. So it be classified as several types according to the onset time. But sometimes I think is usually this kind of acute leak, if it happens in the first week, you are lucky because you still got chance to manage it safely. But once the leak happens in around 2 or 3 weeks, then you have to prepare. The patient will have a very long admission, several times treatment, even under very wear resaturation. That's the first case. Is the patient have the operation in July 17, and around 5-6 days later, he report to our case manager, say he feels something wrong, fever, he feel abdominal pain, shoulder soreness. So we bring the patient back, do the CAT scan. We see the free air under the diaphragm. So when you check data, you see the very high CRP and high in white count. So you know, with the symptom, with lab data, with the CT, you know you're dead. Patient got leak. So this kind of leak, what we do, within the first week, we will try to bring the patient to the OR as soon as possible. So what we do, that's the usual principle. We manage these kind of things. Get in, do the drainage, control the infection source, and control contamination. Once you put this kind of good stable line on the dirty parts, the residual stable become failure, owing to inflammation infection. And try to do a primary repair, close the defect as more as you can. And the third thing I think is the most important I want to share in this talking, do the feeding access. And in the rest, I think if a patient could pass through this kind of procedure enough, but once not, you have to contact your radiologist to try to do a stent, or maybe do asking your GM do some clipping, because it become a long war after this kind once 1, 2, 3 steps did not fully recover your patient. So I think that's the first case I want to share, but it's a lucky case, very lucky. When you get in, you can check, you see the whole unstable line. So let's go back to this kind of leak. I think the majority of this leak happened in the last 1 or 2 stables, always. We're very rare to see the stable failure on the first 1 or 2, always on the end, because it's the most weak, most bad circulation region. So because these patients are lucky, so we did not try to use a suture repair, we just put a stable to do a recut. So somehow that's my personal opinion. Once you do the sleeve, if you make sure all the fundus is corroded, it's better not to make the dual tube too tight, to keep some space. So once this kind of problem happens, you're still able to use stable to do the cutting. It will save you a lot of time and make this kind of repair easier. But it's only a lucky case. The majority of this kind of cases always in a bad structure and not good in tissue healing. So it's just a lucky. Not everyone look like that. Okay. So, but the next thing I want to share is that now routinely when we encounter this kind of leak, even it's a good case, you see it's not a very whole abdominal contamination, but usually we will use the stoma valve, do the enteral feeding. I think that's the most important thing now in our practice. Once you create a good enteral feeding, the nutrition supply is another problem, then you got sufficient time space to manage this kind of heating. Nobody could guarantee this like the stapling or the suturing could make the hole close. It's impossible. But once you put this kind of enteral feeding, you don't rely on the TPN in the future. So the patient recovery will be well and good. Then the healing is just only an issue of time. But the problem is, when you do the scope general feeding, sometimes it's not quite easy. So my suggestion is do the peritonialization, hand the bowel up, and put a hole and put a tube in. But you know how to make the tube as deep as possible is the most difficult thing. It needs some time. So initially, when you do this kind of feeding gel, need around half hours. But now it's relatively easier. But another crazy thing about peritonialization is the angle is quite bad. So it's purely needed some technique to overcome this kind of the problem. So something I would say that the feeding gel is the thing everybody knows, but going to the technical issue actually is for the surgery, for suture is quite challenging. But I think it's not a problem for Parkinson surgeons. So, okay, peritonialization. So once you create this kind of enteral feeding, when you put a good gel, then you got very sufficient space to manage the future of your patient. Okay, let's just skip it. So nowadays, when we encounter this kind of sleeve feeding, I think the drainage, cutting the OP feeder, and the feeding gel is most important thing in our practice. Okay, but what I said, usually when we meet, the leak is always this kind of pattern, not the lucky case as I presented just now. So it's hard to identify. You will see your old tissue in a big mess. Sometimes it's very hard to approach. So whatever, do a well drain, try to close the stoma, let the hole as small as possible, as since surgeons could do. And then will be another miserable story about chronic leak. So usually this kind of chronic is defined at around more than three months. So why? Because after 2 or 3 months, and then the tract fistula become epithelialized. So this kind of leak, this kind of fistula cannot heal by itself. So when you get in, you see this kind of very a lot of fibrin coating. You see this kind of picture inside. So if you're lucky enough, the abscess being not drainage, you can see the fistula penetrate the diaphragm and go into the lung, make a lung abscess. So I think in the future, once this kind of sleeve become popular, not being well managed, you will definitely receive this kind of difficult case from others. So it will become a very big trouble in the future. You need a chest surgeon do the lobectomy, and you need to get in to do the surgery to repair these things. Okay, see the cardiac chest pulmonary fracture. So why it's different? Because it already takes 2 or 3 months. Everything is dense, poor, bad in the tissue healing. So its primary closure is almost impossible. So in our experience, when we need to definitely secure this kind of problem, we need to do the Hsin fistula jejunostomy. But mostly when this kind happens, we always do it on open surgery. It's very hard to do it in scope, so I could not provide you for picture how we're doing. But do a very prepared to make sure a patient in a stable state, a good nutrition, and do the open and fix the problem. Okay, some literature said that this kind of Hsin fistula jejunostomy is good. You could definitely resolve this kind of issue, but once you have encountered this kind of thing, you have to make sure all the team is ready for help you, anesthesiologist, chest surgeon, and yourself. And even after operation, sometimes you need the ICU intensive care and some period of the intensive care for the patient. So when this kind of large leak, is not so common to see, but you know it will definitely happen. Sometimes I would say, like you buying a car, you will know in the future you got a chance to encounter a car accident. So like sleep, I think the part of your life when you choose to become bariatric surgeon. So learn to how to deal with the kind of things is important. But I want to say is, make sure you clean OP field and do enteral feeding. So another thing, we used to talk is the rural gastric bypass leak. It's a long time story ago. So as I said, we did not do this kind of operation for more than 8 years. So this kind of is not so common in our hands right now. The incidence is very low, but most of them need a surgical intervention when this feel or this kind of perforation happens. So the same principle, drainage, take the dirty things away and do the suture of the perforation. But our opinion is once it's not the first time, it's the second time, third time of a perforation of a leak. Sometimes you have to redo the gastroduodenal anastomosis. So at that time, patient usually not so obese. So when you cut the small bowel and do a new GJ, it's not difficult, but it's better. But another thing we will encounter is the stable line actually is a foreign body. So once we encounter this kind of the patient need to do a redo GJ anastomosis, usually we choose a totally hands-on to prevent or leave any foreign body in the anastomosis, prevent not any unnecessary things again. Okay, so I think in the sense what we learn is for this kind of leak, for this kind of things, you need a waste plan and a way prepared for a patient. And the early intervention for acute leak is quite important. Don't wait. Sometimes or 1 day's delay will make your operation difficulty level totally different. And but what time is the two things for breathing, timing, dedicated surgery, and clinical turn over the lab values. So for the next time, also acute or chronic should be dealt in different method. But when you encounter acute leak, try to control source and make OP field clean and prepare your plan B for your patient. So and I think in the last, I may share is for the sleeve right quick bypass, for the breathing or leak trajectory, it's different. For sleeve breathing, do a surgery, go back over if it is the situation out of control. But for when you encounter leakage, wear drainage, put open drain and do a feeding access. It's quite important. And if you have to face a chronic issue, you have to try to do everything. You have to prepare, you have to open the abdomen, not purely by scope. But for right gastric bypass is more friendly. Once breathing happens, usually endoscopic will help you. But for a leak, I think it's better to go back to OR. You have to prepare to do a new GJ for your patient. Okay, that's my last slide. Thank you.